Okay, I think we can begin. I know folks are still filing in, but we have started recording. Hello, welcome everyone. My name is Lauren Anthus. I am with the Center for Community Solutions. Welcome to our virtual Medicaid Institute. For this Medicaid Institute, we're going to focus in on community-based organizations and Ohio's new Medicaid managed care landscape. Next slide. So a little bit about the Center for Community Solutions for those of you who may not be familiar with us. We're a nonpartisan nonprofit think tank based here in Cleveland with offices in Columbus. We've been around for a very long time, over a century. And our mission is to improve the health, social, and economic conditions through nonpartisan research, policy analysis, communications, and advocacy. You can see our priorities there with a strong focus on health and human services. We have a very unannoying, unobtrusive newsletter that comes out weekly on Mondays. You can go to www.communitysolutions.com to sign up for that newsletter. You can also follow us on Twitter at CommunitySols. A lot of our research, our advocacy work is available online. So if you're interested in any of these policy areas, whether that's advancing the well-being of older adults, behavioral health, maternal and infant health, or health and human service safety net issues, you can find lots of resources there. We are knee-deep in the state budget process, but today we're not talking about the state budget. We're talking about Medicaid and Medicaid policy and the role of some of these referral platforms in managing value-based care. Next slide. So a little bit about me and some just general introductions and sort of how we're going to do this today. I want to first highlight our guests. We have Alyssa Glenn from the Greater Cleveland Food Bank. Alyssa serves as the Director of Community Health and Nutrition at the Food Bank, and she leads their work at the intersection of food and health, including building partnerships with healthcare providers, managed care organizations, and leading research on the effect of food interventions on food insecure populations. She's currently pursuing a PhD in urban policy with a research focus on food policy, and she has a master's in public policy from the Heinz School at Carnegie Mellon. We have Cesar Herrera from Healthify. He's the Chief Solutions Officer at Healthify and leads the strategy and development of Healthify's social service networks. He's built social service networks in Kansas, Pennsylvania, and currently in Ohio, and has partnered with payers and provider organizations throughout the country to develop these sorts of partnerships that we'll be discussing today. He has over 15 years of experience in the payer and provider space and has held key positions at several major organizations, including ZocDoc, Horizon Blue Cross Blue Shield of New Jersey, and Booz and Company. He's been a lifelong advocate for addressing social determinants, and he's passionate about bringing about positive change. Thank you for joining us today, Cesar. We also have Tani Stottlemyre from Community Action Incorporated. She's a professional poverty fighter with a passion for social justice and systems change. She leads the dedicated and hardworking team at Community Action Incorporated, a private nonprofit headquartered in Topeka, the capital of Kansas, and she has direct experience working with some of these platforms to address some of these issues. Thank you for joining us today, Tani. We also have with us Kate Reicher Kiefert. She's a subject matter expert in state and federal government health IT policy and interoperability data models. She advises on advancing the use of electronic health information and interoperability for informed decision-making, treatment, operations, measurement, public health, and population health purposes. She advises a number of states, 29 states, through the National Governance Association, the Office of the National Coordinator's HIT Resource Center, and direct state contracts. She's also served as Colorado State HIT Coordinator in the Office of Colorado Governor John Hickenlooper, directing multi-agency health IT strategy and portfolio. Prior to joining the governor's office, she served as the Director for Policy and Public Sector Initiatives at Colorado Regional Health Information Organization, or CORHIO, like the name, and a consultant with Booz Allen Hamilton as the lead technical resource for Kaiser Permanente Colorado Region's Enterprise Electronic Health Record implementation. She has a graduate degree in technological management from the University of Denver and is a certified project management professional. Thank you for joining us today, Kate. And last but not least, we have our moderator, Heather Stoll, a friend, a colleague in many respects, a fellow advocate, and also a member of our board. So please, Heather, pass along the incredible success of this webinar to the fellow board members and to my boss. That'd be great. Heather is a vice president of external affairs at the Sisters of Charity Health System, where she oversees communications and branding strategies to promote the mission of the health system. She also coordinates the development and implementation of government affairs and public policy initiatives. Beyond her external affairs role, she provides administrative oversight of Joseph's Home and Building Healthy Communities, both of which are ministries of the Sisters of Charity Health System. She's previously worked at Hopewell Inn in Mesopotamia, Ohio in fund development. And there she worked directly with the organization's founder and board of directors to develop a fundraising program for the newly created residential treatment center for individuals with mental illness. She's a Cleveland native, a graduate at Smith College. She holds an MBA from Weatherhead School of Management at Case Western. And to be honest with you, I think we could spend the next half hour about all of her accomplishments. Thank you for agreeing to moderate and joining us today, Heather. Again, I'm Lauren Anthus with the Center for Community Solutions. My background, in addition to being a Medicaid geek, I hold a Master's of Business in Healthcare, and I teach at Ohio University's Heritage College of Osteopathic Medicine, where I focus in on population medicine, quality improvement, that sort of stuff, and work in public policy. Just so you know, we will be recording today's presentation, so you will be able to find a recording of this on our site, and we also will make all slides available. So for anyone who has been on webinars before, all the materials will be available to you after the conclusion of today's event. I will also say that if you have questions, to put them in the chat. We will moderate them at the end of our panelist presentations. What we're going to do today is sort of start out from a national perspective and then move into a local perspective about what these referral platforms do. Heather will then lead some of the discussion with some prepared questions and then take questions from the audience. So if you have questions that they get developed, please enter those and we'll make sure to try to get to those as we are able to with the time. All right, next slide, please. So this is always good to double down on. Slides will be made available. Enter your Q&A into the chat. Also, please frame your question as a question. Very important. You know, we want to make sure that this is an educational process because it's part of our mission, Community Solutions, to create understanding. And again, we're recording and a copy will be made available online after the event. Next slide, please. Okay, so why are we interested in this as a Medicaid Institute? You know, we've done these events before where we've talked about different discrete areas, but I think it's really important to understand what we're ultimately talking about here. When we think about risk in insurance terms, risk is the likelihood an insured event occurs. So in a population, the risk is distributed based off observations and experience. And when we think about medicine, when we think about healthcare, traditionally the fee-for-service system really rewards us based off of the highest, most intensive service, right? So this is what we mean when we say disease-based care. The reason why we have a lot of heart hospitals, the reason why we tend to pay more for diabetic amputations than we do managing diabetic populations or pre-diabetic populations. In fact, the United States just last year became the first industrialized nation to see an increase in mortality relative to other nations since the 50s. And this is in part driven because of the opioid crisis right here in the Ohio Valley. So, you know, when we think about system design, when we think about ways to improve our system, we have to understand that, you know, our history is one born from incentivizing the wrong things. The incentives align with providing more services at higher prices, not prevention, not going upstream. Next slide, please. So when we think about value-based care, and you know, I'm a person who likes to unpack some of these terms, right? We have all these different initiatives, MIPS, CPC, we have episodic-based treatment, we have PMPM incentive payments, so on and so forth, SDOH, closed-loop referral incentives, so on and so forth. Really what we're talking about is shifting the incentive, moving more upstream so that it's about achieving outcomes. You know, so these payments can be upfront, they can be global, they can be at risk, meaning that the provider's risk exposure is the same as the payers. So, you know, insurance and providers are coming together to say, well, we need to focus more on the pre-diabetic population and move away from the incentive towards disease states. So with Medicaid, with Medicare, with payment initiatives generally along the lines of value, it's all about lowering the risk exposure of payers like insurers, Medicare and Medicaid. And I think it's fair to say, with the latest iteration of the managed care procurement in the state of Ohio, there's a significant and greater focus on addressing all the elements of risk and how we think about insurance risk and what does it mean to try to prevent some of these downstream outcomes that we've seen in the United States. Next slide, please. So this comes from the Health Policy Institute of Ohio. It may be familiar to many of you, but social determinants, if they make up 40% of what leads to outcomes, and clinical care only represents 20%, then our incentive structures, our reimbursement structures have to align to try to address those issues. But we can't institutionalize everything, right? It's not enough that hospitals or major medical providers try to bring it within their walls. That's not going to be a sufficient answer. We have to think about ways to create connections, to create partnerships, and rely on health and human service agencies, social service agencies, community-based organizations who are already doing this work and try to incorporate them along the lines of value in meaningful ways. That doesn't mean that we try to medicalize everything, right? We don't need to turn the food pantry into a hospital clinic, but what we need to do is recognize through our incentive systems, through our data systems, through our contractual processes, through software, ways to create meaningful partnerships with organizations like food pantries so that when you are a physician engaging someone who is pre-diabetic, that you realize that that person may be food insecure, that just printing out the SALT diet and handing it to them is not going to be sufficient, that you have to do something more meaningful that meets them where they are, that addresses the issues more systemically. And that's what the role of these referral platforms ostensibly intend to do. So today with this panel, what we'd like to do is really talk about the role of data, how that data gets operationalized through these sorts of networks, and provide some real world experiences both inside and outside of Ohio to describe the potential and then answer whatever questions you have. So next slide, please. I just want to highlight this point this last point here because I think it's important. Regardless of how we may feel about this particular product or this move generally, one thing I think is really important to highlight here, and I draw this from a Milbank quarterly publication that came out just a couple months ago about how we are operationalizing or trying to address social determinants. I think Medicaid can do a lot. Medicaid can try to innovate in policy in ways that create better systemic connections to address the needs of individuals, the social risk needs of individuals. But for someone who's housing insecure, what you need is greater housing and security. For someone who's food insecure, they need better access to food. They need to have easier access to SNAP benefits. They need to not be in a food desert. If we have income disparities, we need to address those disparities. Medicaid can't do it all. And community-based organizations need to be empowered through the system, but it's important that we think about how to work with community-based organizations to help them build capacity to professionalize without necessarily medicalizing them or making the partnerships just really an extension of a particular type of interest. At least that's where I'm coming from on this topic. So I'm more than happy to ensure that this is some of the material that gets passed out. But at this point, I'll stop pontificating and I will hand it over to Kate, who will kick us off with presentations. So Kate, if you want to go ahead and begin. Thank you.
Great. Thank you very much. Thanks for having me. Let's go ahead and go to the next slide. I'll just go ahead and jump right in. I'm going to walk through some different activities that are happening at the federal level with executive orders and bills, as well as with the federal agencies that I think are going to be important to show that there's a lot of priority of addressing social determinants and use of data and technology to do so. There's a lot of opportunity. I think that understanding what's coming down from the federal level is going to be important for those state level activities as well as the community level activities and how to meet those operationalization challenges that I think can sometimes happen when it comes to moving all of this forward. Next slide, please. This is just a grounding point to show, the social influences that greatly impact health. All of these, and my specialty is at the state level, but when I worked at the state level, all of these were different organizations, different agencies were focusing on these different activities, often these to address education issues or employment status or income or community safety or substance use or healthcare. All of these were being addressed by different agencies within the state government or with different organizations around the state. So there's an opportunity for alignment on what is happening and coordination to help really address those conditions of where people are born, grow, work, live, age, in the wider set of systems. So I think that there's an opportunity from the federal to the community level to help align and address these activities. Next slide, please. So I'm going to go through a few things. Many of you probably have seen these before, but I want to try to connect the dots across all of these because I think that there's some of these are going to demonstrate that there is a prioritization at the federal level around social determinants data and activity to help inform what is happening and also address and make innovative programs and fund activities to help address these things. So at the federal level, there was on January 21st was an executive order ensuring the equitable pandemic response and recovery. And I think that this is a good North Star for the administration to show these are the things that are important. COVID-19 pandemic obviously impacted everyone, but it also disproportionately impacted high rates of different folks from different socioeconomic backgrounds, different race, ethnicities, and but I think that what also showed was there was a huge shift in a need for other social support as people had different economic changes. Maybe they lost their job, or their house, or there's different parts of their life. So the executive order is going to convene a task force, and they're going to support recommendations around health inequities that were exacerbated by the COVID-19 pandemic. It's also going to recommend how agencies from state, local, tribal, and territorial officials can allocate these resources to certain communities. It also identifies some very specific things around data-driven response to COVID-19 and public health threats. And then also a longer-term recommendation around addressing data shortfalls, foundational data challenges, and data intersectionality to be tackled and prepare and respond to future pandemics. What I really love about this is around the equity data collection, reporting, and use. It doesn't always have to be around just COVID-19 because I feel like COVID-19 is across everything, but this is really important to show that from the White House that they are identifying that data is important to understand what is happening out there, how it can be used, and how can it inform these different policy decisions. The links are there. You can go and find a little bit more about it. It does also speak to, I want to point out that about aligning across the different agencies. So many federal agencies are trying to address this, whether it's CMS with Medicare and Medicaid policies, there's CMMI with different innovative payment models, CDC, ONC, I could list all the acronyms, but showing that this has some collaboration across agencies, I think is going to be really important. Next slide, please. So also, there are a couple bills going through the Senate right now that I think is going to be important to show how to, again, proliferate the different priorities around social determinants. LINK is one, it's Leveraging Integrated Networks in Communities to Address Social Needs Act of 2021. This is going to be focused around supporting the framework around food, housing, job training, and other social needs. What's also really important to me about this one is that it also aims to establish or enhance technology platforms to enable coordination for public and private social service providers and healthcare providers across the states. They also identify the privacy concerns. There's also, they strive to improve data sharing amongst the community organizations, to measure the impact of social interventions, and create sustainable funding models for long-term accessibility for these integrated community networks and with cross-sector collaboration. So which I think is completely in line with today's conversation. That's going to be a really interesting one to follow. It also complements well with the Improving Social Determinants of Health Act of 2021. This was originally introduced in March of 2020. Obviously, there were different priorities that we're going through, but this one focuses around, again, that coordination across CDC to ensure programs and incorporate social determinants of health in grants and activities. Financing is always a challenge for states and communities to figure out how to invest in technology platforms or community activities or shared platforms across the communities or statewide. So this identifies different ways to award grants to state, local, territorial, and tribal health agencies in target communities, awarding grants to higher education to conduct research. For research, you're going to need some data, and that's going to be an important part of this as well. It also talks about coordinating, supporting, and aligning these activities with other federal agencies, and mention CMS, and then also collect and analyze data. So you start to see a theme here: coordination, alignment, data, technology. What I do also want to focus on these things is I think that there's an opportunity for, a lot of times these funding streams can be kind of siloed as they come down. I think that there's an onus on communities and states, state Medicaid agencies, to help do that coordination across the different activities, and making sure that you are aware of where are different groups getting funding for what grants, because having that situational awareness is going to be really important, so you don't reinvest in technology that's already there, or try to reinvest in programs that might already be happening 20 miles down the road. I always say that it's like a wedding, and everyone's there for the same wedding, but everyone is sitting in different circle tables in the banquet room talking about the same thing. So how do you make sure that everyone is aware of how all the funding is coming down, so you can really maximize it to really address and support your communities? Next slide, please. So some of the federal agencies, this by all means is just two of a very, very long list of what the federal agencies are doing around social determinants. I do want to point out around the CMS State Health Official Letter, which came out in early January. It identified different ways that the Medicaid agencies have opportunities to address social determinants of health. They identified what specific programs Medicaid and CHIP can offer services and supports to address the social determinants of health. It also identifies which ones are commonly covered, what are federal authorities and other opportunities that states can use to address social determinants. And they also identify a table that summarizes the information for these key authorities. What's also important in the State Health Official Letter is it identifies specific needs for standardized data, community data exchange, reusing health IT or technical infrastructure that CMS has already paid for. A lot of states have pulled down federal participation to maximize some federal funds to fund some infrastructure in the state that can be reused. But this really goes in and talks about these are very specific programs and how they can address it. And it does point out the importance of the data and data standards in order to help enable those programs and enable the data for transactional individual support, but also data exchange as well as population health. The next one I want to point out is the ONC US CDI, the US Core Data for Interoperability Task Force for 2021. The US CDI is adopted as a standard in the ONC 21st Century Cures Act. And this is going to have the standard that the certification standards that certified electronic health record technology vendors have to adopt. This is also kind of the basis for a lot of policies. You're going to start to see in payment models, you should be able to support the US CDI. And so it's just something that I always want to point people to. It gets a little weedy, but this is something that's important. The one thing about it is they passed version 1, and just recently version 2 was just discussed at the Interoperability Task Force, and they did recommend 9 additional data classes and data elements as they pertain, and they do include some different data elements for social determinants of health, which I think is a significant leap forward in going from clinical data collecting to more standardized social data elements and context created, and making sure that the technology can support them, and that's going to help adopt standards, and that's going to help adopt usability and reusability of that data. So keep an eye on that. That's going to be big. Next slide, please. I just also want to point out a national collaborative. Gravity Project is a national consensus group. They work with, I think about 1,800 different people come, and they're trying to figure out how to do consensus-driven data standards to support social determinants of health. They're doing it at the standards, the data collection point with surveys, assessments, diagnosis, and interventions, but they're mapping these codes across these different domains, which can be very, very different, to coded elements. And those coded elements are going to be really important for any incentives, any payment models, any metrics. If you can get all of them to align to an ICD-10 code, it's going to help with the reimbursement and payment of those services that the social organizations and community benefit organizations provide. So this is starting to not get into the medicalization of it, but get the different service organizations and care organizations on the same page to use the same codes, so they can actually start to really support that reimbursement aspect, which is really going to be important for sustainable funding for these services. Next slide, please. I think this just goes through that Gravity is working on the screening, diagnosis, goal setting, interventions, but that's one part of it. And we can go to the next slide, please. What I do want to point out is there are definitely challenges here, and I think we'll have to click through these a little bit. Some of the challenges here are the data for social determinants is it's not always accessible and actionable as medical data is, and Gravity Project is working through that. There's also various ways that social determinants data is collected. Sometimes it's in an Access database, sometimes it's in a Salesforce, sometimes it's in this. So having the data collection and where it's coming from and if it's available is going to be important. Making sure that there's a consensus and a use of standards and incorporating those standards into policies. Financing for all these activities is very important. And then how do you put the information together so you can start to aggregate it? And this is probably my passion, where I should probably do a PhD around, is governance, is that there needs to be a governance, and not only a community organizational governance, so you know who is doing what roles and responsibility, but who has the data, who shares the data, for what purposes and what uses, and how do you make sure that there's a framework for these shared community resources to make sure that there's accountability enforcement to improve the trust and improve the services to help the community and the population. Next slide, please. I think this is my last one. Yes, this is a busy slide, so sorry about that. But this is how I break it down, because sometimes people say, they start to conflate the terms in different ways, and I break it down in this way. Starting to the left, around sometimes this information is going to be needed for care, identification and care and services for an individual or a family. That's going to be your first yellow column there about clinical and service delivery for individuals and family. You're going to have to collect different data for this. There's different technical functions around this. In the middle, you have your community data exchange. That's going to be your referral, closed loop referral across healthcare to CBOs, CBOs to CBOs. What about CBOs to benefits eligibility, say the SNAP TANA for Medicaid program in your state? So the first is really focusing on how do you identify what an individual or family needs. The second is how do you share the data across those organizations. And the third column is around population, community health prevention and risk assessment. How are you going to take all that data, reuse it, aggregate it, reuse it, and analyze it? You can't analyze anything if you don't have the data to analyze. So I always say it's individual, across, and then the population. And this slide just goes through different data workflows for those individual, those different sections, and then talks about different functions and features that you might have to have in place in order to support those different actions. And there's some data examples at the bottom. It talks about individual level to population level. So sometimes when I work with groups, I say, where do you fit? Are you the bridge? Are you a collector, data collector, where you're going to be providing the services and providing the case management or identifying services for someone? Or are you at the aggregate level with population data, doing your analysis and your risk attribution, and you're finding what the populations need and designing your community interventions? So this is just a map to show everyone fits, but where do you fit in this, and what are some different ways to map this out? So hopefully that was helpful. From the federal, there's a lot of things going on. And just be aware, there's a lot of activities, there's a lot of potential funding coming down, a lot more alignment to come down, and a lot more coordination that's going to be absolutely needed across the community and across states. But this is an exciting time where it's a priority for the nation. So thank you very much.
Great. Thank you so much, Kate, for that really fantastic primer in regards to all the policy initiatives that are now enabling us to think about SDOH. And quite frankly, it's a really good segue into my presentation here. We're really going to be talking about Healthify is just one of many platforms that I'm sure that you've heard about that we're talking about here that really helps in driving this connectedness. So just a brief statement in regards to who we actually are here. So how we describe ourselves is not as a platform, it's not as a piece of technology, but really as an infrastructure organization. What that means is we're really here to drive to that connectedness between disparate stakeholder groups that are really trying to help coordinate social services on behalf of vulnerable populations. And we recognize, especially since the beginning of our journey here in this space, that a piece of technology alone does not solve that problem. It really is an enabler, but there's so much more to it than just plopping down a piece of technology and just hoping and praying that people use this. Especially given that we already have existing infrastructure in place that's used by multiple social services stakeholders, and how do we connect them all together? And that's really what we're talking about here as what we strive to be at Healthify is providing those connections into a healthcare ecosystem, making sure that there are strong relationships in place that have accountability on all sides of the stakeholder system, and then making sure that there's transparency and standardization of that data that can then be visible at all sides so that we can actually get to a point of value-based care or proving out outcomes associated with social services in that landscape. Next slide, please. So I don't necessarily need to belabor this point because Lauren and Kate really spoke to this, but what we're seeing here, right, is a lot of shifting policy enactments that are enabling us to really think about this. And as a result, states and private entities putting their money where their mouth is as it relates to thinking upstream around social services. So you see examples here from full states of like North Carolina, where they put in $650 million for Medicaid funding specifically for direct reimbursement of SDOH and interventions. You have CareSource in the state of Ohio that has committed $50 million in affordable housing investments, knowing that their populations are adversely affected by housing insecurity. And then you have states like New York that are taking one step further as well and formalizing this by requiring all Medicaid managed care organizations to actually incorporate CBOs, community-based organizations, into their value-based contracts, right? And finding ways for us to actually systematize this process to not only provide better access to care for those individuals, but also to create better sustainable funding structures for community-based organizations to keep those social services actually in the community where they're most productive. Next slide, please. So that's really what we're building out here. In this case, in Ohio, we're building out a multi-stakeholder community network to better connect all the meaningful stakeholders that are really addressing the complex social needs of all Ohioans, right? So this means it's not just a platform that we then give specifically to CBOs. It's a platform that we enable it so that every stakeholder in Ohio is able to connect and share data across the board to prove out outcomes associated with the services that are being rendered for any individual. And we know that there's multiple care and service providers that touch any individual, particularly those in disenfranchised communities. So that includes the CBOs, who are direct service providers. That includes what we deem as conveners, which is a broad-based term for any organization that, like a foundation or a membership association that collects or convenes multiple CBOs at scale. It includes our health system and providers. It includes our health plans for which we have direct relationships with. And it also includes our public agencies like JFS that are making and coordinating services as well for state benefits. And then we also have national service providers that are able to provide specific services at scale to be able to create better access to services within the network, but also to ensure that we're connecting everyone together so that we're coordinating these services and have actual data in place that can be shared across all of these stakeholders. Next slide, please. So this is much more specific to, say, CBOs that were joining this network, because we know there's an upfront investment in terms of just time and resources to participate in such a network, and we're not naive to that, right? So how we really think of ourselves here is how do we better support our CBO partners to ensure that they can actually engage in value-based relationships or even just financial reimbursement opportunities within a clinical ecosystem, especially if they've never done that before. So one of those key pieces, as we've talked about, is access to data and coordination. So in this case, many health systems just don't know what services or social services are being provided for their individual members, but they have all the claims data and all the clinical data to be able to prove out outcomes if they only knew what services were actually being rendered. And that becomes really great visibility that we can then share back to CBOs so that you can then see for all of these services that you're documenting and visualizing across the network, what kind of impact does it actually have on a Medicaid life. The other piece is just exposure to community and healthcare stakeholders. You have the ability here to be able to just make additional referrals or connections into other organizations that you might not have before, and then also make your services more visible, in this case to healthcare stakeholders that may not have known about the services that you may provide. And by doing so, you can then strengthen your healthcare relationships. That's a lot of the work that we do is not really in the technology, it's in the connection. So brokering relationships between our health system and health plan partners and our CBO partners to establish, in many cases, direct reimbursable contractual relationships and or beginning stages of those types of deeper relationships that get to value. Next slide, please. All right, so we're just gonna walk through really quickly so we have an understanding of what exactly does it mean in the platform to be able to connect these services in and what kind of data is actually shared across the board. Next slide, please. So we're gonna use Jose as an example. So Jose's 50 years old. He lives with his teenage daughter. He's a Medicaid beneficiary. In this case, he's being managed by CareSource, Medicaid health plan in Ohio. He's recently lost his job, so is really struggling now to make ends meet, and that's obviously impacting his care. Next slide. So we're gonna walk through here the beginning of this workflow, and it starts at the care manager on the health plan side. But note, there are multiple ways in which the care journey within the network can begin, right? We all know that usually the health plan is not the first point of care or coordination for an individual. In many cases, it's directly at the social service organization, first and foremost. But let's just use this as an example. In this case, that care manager is already conducting regular monthly assessments for Jose. He's already in a care management program because he's been deemed as high risk or high cost. And in that, through the social needs screening or through just regular conversations, their care manager has identified that there's an opportunity here for Jose to be connected to employment assistance, especially since he just lost his job. Next slide, please. So within that, then the care manager is able to go into the network, in this case, leveraging the Healthify platform to do so, and sees a whole slew of potential resources that are available. In this case, ABC Job Success Program is in the Healthify network, and is identified as such when the care manager logs into the platform. So the care manager decides to make the referral directly to ABC Job Success Program. Next slide. So what does that actually mean then? Is that The care manager sends that referral directly within the platform, and then ABC Job Success Program can actually pick that up in the platform. And there's numerous things that can then be enabled through this. One, they're able to coordinate directly with each other. In this case, ABC Job Success, the referral manager there, and the care manager within CareSource are able to actually coordinate in real time. They're able to send messages back and forth. They're able to send documentation that may be needed for Jose to fill out in order to qualify for services. And they're able to, and then ABC Job Success is able to then update the status of that referral so that the care manager at CareSource is then able to see where services actually rendered, what are the next steps associated with this individual. And then also, just equally importantly, is we know very clearly, and we all know here in the audience, that most likely Jose's social services needs don't end in employment, right? There are numerous social service needs that likely will pop up as a result of this. And the referral manager or the intake person or the case worker at ABC Job Success is then able to then make additional referrals into the network as appropriate for Jose. And all of that data is shared across this network, is housed so that we have that full record associated with all the social service needs and programs that are being addressed for Jose. Next slide. So the great point of this is that then any services that are then being rendered for Jose across the network is housed and is standardized and then can be shared back, in particular here with the health plan, who has a ton of data around total cost of care, around clinical outcomes associated with Jose. All these referrals are at the member level so that we're then able to see what kind of impact did that actually have on Jose's treatment. What does that mean to his total cost of care? Is he now more engaged in his own healthcare? Does that mean that we've seen a reduction in his cost of care accordingly? And that data, as we continue to work with our health plan sponsors, can then be shared back to the network partners. So any CBO then gets visibility in, well, what kind of impact did my services actually provide to Jose, which is incredibly important as we continue to do this work. Next slide. So I know I spoke really briefly there and really excited to answer any additional questions that people may have in regards to just in regards to this topic, or more specifically about Healthify, but I can't end without just giving a really quick plug for those CBOs that are out there that are interested in understanding how they could leverage a platform like this to support their use cases, support their programs, how they can get better connected for additional funding streams with health plans. Please feel free to reach out to our team at networks@healthify.us, and this information will also be shared back to the attendees on this list.
Thank you, Cesar. Looks like something's changed about me since that photo was taken on the screen there. I am Tawny Stottlemyre. I'm the Executive Director of Community Action. We are an anti-poverty organization located in Topeka, Kansas, which is a small urban community. We have about 178,000 people in our community, about a 19% poverty rate. And we also happen to be the capital city of Kansas. So if you were looking back at your high school geography and capital city list, you would have known that. One of the things about being a capital city is that we have a lot of nonprofit organizations located in our community, more so than you would the average community that doesn't house the State House. And so I think that's important to note as I talk to you about our experience in this world and this network. I'm a fan of a slide deck just as much as the next person, but you're going to get to look at my face as I go through this, because it's been a really, really busy week here, and I haven't had time to put slides together for you. And that's what life is like on the ground. And most of you know that. Most of you know when you're working directly with a population that it's constantly go, 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 meet the needs of this funder, meet the needs of that customer, try, to build and forge these relationships that we're talking about in this particular webinar even. So you get to look at me as I talk. Community action provides a wide variety of supports to our customers. As I indicated, we are an anti-poverty organization. And so we're doing everything from early childhood and basic needs with our customers, to affordable housing, to working with seniors, and doing things on the innovative side. Right now, we're piloting a project to work on 2-generational approaches to fighting poverty. And we do advocacy work. So we are all over the board. In 2018, we did 156 focus groups and talked to people and said, tell us what it's like to be in poverty. These were all individuals that lived in poverty. And tell us what's holding you back. Tell us what would help you, get beyond those barriers. And it was, first of all, a really incredible experience. Listening to customer voice is one of the most powerful things that we can do as a local community-based organization. And what they told us, in fact, this surprised me at the time. It was in 2018. And when we asked about what's holding you back from being more economically prosperous, I expected to hear my job doesn't pay enough, or I expected to hear I have huge medical bills that I just can't overcome. Without doubt, every single group that we held on their own self-identified that the number one thing holding them back was racism and perceptions of racism. And that was really eye-opening for us as an organization. They also identified lack of control, that everyone wants to case manage their lives. Everyone wants to tell them how to spend their resources. And they said they were overwhelmed. They said, I am being case managed from 19 different directions. And there are so many places that I could look for help, but then when I do, there's different paperwork that different people want me to fill out, and it just gets exhausting. So that's what we learned from input from customer voice. And when we looked at it, and I looked even within our own agency, it was really clear that over the years of becoming an agency that did so many different things, we had also created our own silos. And that even to navigate their journey through a community action agency, our customers, if they needed rent assistance, had to go to the rent assistance person. And if they wanted to enroll in Head Start or Early Head Start, they had to start all over and go to the Head Start or the Early Head Start person. So the first thing we did was focus internally. And we worked on breaking down those silos and assigning a person, a staff member, who would be our customer's partner through their journey with our agency to help eliminate the barriers of just making it through a community action agency supports, let alone all the other things that our lower income customers have to do to survive in this world. So when you look at everything that a customer has to be involved in, not only within an organization like ours, but you look at all the other nonprofits and the managed care folks and the hospitals and the schools and our welfare departments, right? everybody's working to case manage, but it's really, really hard. And this is my 31st year in this business, so I speak with some experience. I know I look like I couldn't have been in it more than 10, but trust me, I speak with some experience that I say none of these systems play very well in the sandbox together, let alone do something as serious and meaningful as changing people's lives. And it is a really difficult barrier to overcome, even to do something as seemingly innocuous as sharing data about a customer that you're both working with and whose life and whose livelihood you both have a vested interest in. It's really hard stuff. So when you enter this territory, I think that it's critical that it be non-threatening, because every organization out there is worried about their territory or is worried about their funding and their supporters and donors and volunteers. And then there's your government organizations who are scared of everything, but certainly afraid of violating any rule or regulation that has been put in place for good reason, but also in ways that really prevent barriers to this playing in the sandbox well together. So it has to be in a way that's non-threatening and gradual. You can't just jump into the ocean and learn to swim. So when we got involved in Healthify, is the system that our community is using, some of the things that have really made that beneficial to us are that, first of all, the Healthify team was persistent and engaged. It's not bothersome per se, but they certainly continue to tap on my shoulder and say, we need you at this meeting. We need you to be a part of this planning process. Okay, we're ready for your onboarding. You need to make sure that you're there. So they've been a constant source of support from outside of my day-to-day life to make sure that that happens. I think another thing that's made it helpful is that we started small. We had a very small group of organizations that got together, and we spent 5 or 6 months meeting and talking about how it would all work before we took the plunge. And then COVID hit, and that made it difficult. But we're still moving forward. I really think we'd be further than we are today, if COVID hadn't hit. But starting small helped, and actually having this time to sort of build up and get folks used to the system has been very helpful. A third thing that has helped is peer-to-peer communication. Once we became involved and I saw what Healthify could do for us as an organization, but more importantly, could do for the customers, if we were able to do better overall sharing of information and connecting that customer to meaningful interventions, I started talking to my peers, just subtly and one by one, hey, I'll just throw in Salvation Army as a placeholder, even though it's just because that's someone I think you'll all know. I think you should really look into this. I think it would be valuable, and I wouldn't recommend it to you if I didn't think it was helpful for lower income people. And that kind of peer-to-peer networking has helped. And I'm not the only one doing that. We have others in our pilot group that are doing that as well. But I think that's important. Another thing that made it really important for us, and Cesar has probably heard this over and over again from Janelle, our local representative, but I went in kicking and screaming because I've got 19 different funding sources, and most of them have their own damn software that they want us to use. And if we don't use that software, then we're not going to get their funding and we won't be able to provide the service. And it's a mess. Any local social service provider of any size can tell you that. And I went in saying, Okay, I'll come to your meeting, but I definitely don't want another piece of software that I have to use. And the only way this is going to work for us is if we work out some sort of interoperability between systems. And we haven't gotten that far yet, but that's only because we were, I think, slowed down in our process. And because my agency hasn't gotten that far yet, we're trying to still make our own backyard clean with our data. But that's been really helpful, knowing that my team isn't going to have to do double data entry forever, because nobody pays for that. Speaking of paying, I want to mention perhaps one of the largest benefits in terms of us agreeing to take part in this kind of network is that it's not costing our agency anything other than the staff time to learn the system and use it. Our Blue Cross Blue Shield affiliate has made it available to our entire community, which is amazing, because again, as a local agency, we don't need another unfunded mandate or unfunded project to provide data for the greater good. All well and good, but someone has to pay for nonprofit services, whether it's direct services or data collection. It's all for the greater good, but somebody has to pay for it. So not having to do that has made a real difference for us. You know, I could go on for 5 or 10 minutes, but I'm looking at my bullet points and I think that I've hit all of them for you. I just want you to know that our staff took really well to the system. They too grumbled when I came in and said, I got a new software thing to introduce to you. But then they went through the training, and I actually got emails from some of our frontline staff, like, which never happens after a training session, but they were like, wow, I was really impressed, and I want you to know how easy I thought this was and how good it's going to help our customers. And we're using it. They're making referrals. Our network is still smaller than I would like it to be, but they are using it, and we're getting referrals and making referrals. So the staff have taken really well to it as well. And with that, I will open later for questions when it's time to do that.
Okay, thank you, Tani, for your words, but also for the break in slides. I know I appreciate a slide break. That said, I've got slides, so apologies. I'm Alyssa Glenn. I'm the Director of Community Health and Nutrition at the Greater Cleveland Food Bank. And I'm gonna use my time to kind of be a case study of a CBO that has some experience in using a referral platform. But I'm gonna start with an overview of our operations, because I do think that it's important to understand how CBOs operate and what their data looks like, so that you can really understand how these systems need to be created and implemented. So this is a picture of our warehouse. We are a very large warehouse and distribution organization, been around for about 40+ years, and our mission is to ensure that everyone in our communities has the nutritious food that they need every day. Next slide, please. This is how we work in the community. The Greater Cleveland Food Bank receives donated food and money. We warehouse food on site, and then by and large, the bulk of the food that we get into community members' hands goes through our partner agencies and programs. And that's a really important thing to understand about the Greater Cleveland Food Bank. We are not a food pantry. Sometimes there's some confusion between food pantries and food banks. We're a food bank without an on-site pantry, although that's likely to change in the near future. Next slide, please. This is our service territory. We cover 6 counties: Ashland, Ashtabula, Cuyahoga, Geauga, Lake, and Richland counties in Ohio. And if you look at the numbers on the screen, these are estimates for food insecurity. They were updated in early 2020. And you can see that there are estimated to be well over 300,000 food insecure individuals in our service territory. And a great bulk of that need is in Cuyahoga County. Next slide, please. This is a snapshot of our different types of member agencies and programs. We offer a variety of different types of programs. And again, these are the way in which that food reaches community members. So we have everything from your traditional brick and mortar pantry partner. We have about 240 of those throughout the community. We also do a very large number of mobile pantries or produce distributions. This is where thousands of pounds of fruits and vegetables are loaded onto a truck and then dropped off on a regular basis at our partners. We create a farmer's market-like experience, and community members can go through and increase their consumption, hopefully, of high quality fruits and vegetables. Next slide, please. Okay, so these next 3 slides, what I really want people to understand is just how distributed our food network is. So this is Cuyahoga County, and we're showing 2 things on this slide. One is poverty level. So the blue indicates % of poverty. The darker the blue, the more concentrated the poverty. And the dots on the slide are the locations of our partner programs and agencies. So this is in 1999, and around that time, we had about 300 partner programs and agencies across Cuyahoga County. Now, if you flip to the next slide, you will see that poverty has both concentrated, gotten worse, and dispersed. It's coming out of the core quite a bit. So to meet that need, we started with more, more partners and programs. So at this point, we're up to over 500 partner programs and agencies. And this was in 2009. So now fast forward 10 years later by going to the next slide. And we can see, unfortunately, that that trend has continued. So there's, again, more poverty extending out beyond the core, and again, an increase in our number of partner programs and agencies to meet that need. So at this time, this was just a couple years ago, we had over 800 partners spread throughout Cuyahoga County. And at this time, in 2021, across our 6 counties, we have over 1,000 different partner programs and agencies that are distributing food to people at need. Next slide, please. So just a little bit about our data systems. When people access emergency food, so that's the food that's provided through pantries and through mobile pantries and produce distributions, we do have a record of that food access. And we are very lucky that we can use Pantry Track, which is a web-based software to document that access. So this is a snapshot of Pantry Track. This is what it looks like when I log in. And if you look at those yellow boxes at the bottom, so those are the different types of service events that the Greater Cleveland Food Bank offers. But that's just our account. So our partners represent over 400 accounts on Pantry Track that we're servicing with food. So just in this calendar year alone, we have served over 65,000 unique households. Again, that's through our partner network. That represents 166,000 plus unique people that are served, because households typically have more than one person, through over 210,000 different service events. We do collect basic household information on Pantry Track. So for example, we collect household size, number of seniors in the household, and number of children in the household. Next slide, please. Okay, so I'm going to talk just a couple of minutes about our Food is Medicine programming. This is really our programming with healthcare partners, and there's increased interest from MCOs on this front as well. Next slide, please. So this slide really demonstrates the why. Why do we have partnerships with healthcare providers? Why are these referral platforms so important? Why do we need to grow the connection between healthcare and social service? So food insecurity, we now know, has been studied for a long time, and it has a strong relationship with chronic disease. That relationship is really twofold. Number one, food insecurity increases the likelihood of developing a chronic disease. And there are just some statistics to that point. Hypertension, your odds go up 25%, same with diabetes. Kidney disease, 50%, osteoporosis, 400%, and those are just some examples. Number two, food insecurity makes it harder to manage the chronic disease once you have it. So It really increases the number and severity of tough choices you have to make, how you're going to spend your dollars. You're going to spend your money on medication to manage your disease, on enough food. It affects your quality of food that you're purchasing. Are you going to spend your money on transportation to your doctor's appointments, quality housing, or even any housing? We know that food insecurity decreases medication adherence. And we also know, for example, that diabetics have worse glycemic control and more emergency room visits. So again, this is the why. This is why this work is so important. Next slide, please. Now, the referrals that typically happen as a result, and most of the time should happen as a result of screening for food insecurity. So this is the Hunger Vital Sign. It's the validated 2-question hunger insecurity screener. So when patients are screened for food insecurity, hopefully they're using this particular screener because it really is the gold standard and go-to. And if patients answer often true or sometimes true to either of these 2 questions, then they're considered to be food insecure. And then that would hopefully trigger a referral to food resources. Next slide, please. So this is the services that are currently offered through the Greater Cleveland Food Bank for food insecure patients. The first bucket really is this concept of food interventions and food prescriptions. So this is typically happens, it's a combination of a positive food insecurity screen and having a particular health condition. Frequently diabetes and hypertension are targeted, but it could be, whatever a healthcare provider or managed care organization wants to work on. So that combination of conditions results in a referral to a dedicated food pantry or clinic that has highly nutritious food available on a regular basis. And the goal with this type of program is to increase consumption of healthy food and improve the outcome of that health condition. So data tracking becomes very important in this situation. The second thing we do very frequently is offer produce distributions on site at healthcare providers. And the goal is really simply to increase consumption of fruits and vegetables. It could be preventative, it could help people, manage their condition, but really just working on a population health improvement with this. Now, the third bucket, and the one that's probably the most relevant to this conversation today, are referrals to our help center. So our food bank is a little bit unusual across the landscape of food banks in that we have a very robust help center and outreach staff. So we have 6 full-time help center employees and 14 full-time outreach staff that do the same thing but go out into the community to work with clients. And they do a bucket of things. So one very important thing is that they are able to tell people based on their location who have needs. So if I were to call the food bank and say, I need some food resources, they would ask me my address, and they're able to pop up on their screen a Google map that shows that variety of food resources in the community to really help them find the most accessible and most useful emergency food resource to that individual. And that's really important because, as you saw from the map, we have a lot of food resources in the community. And there are varying hours of operation and varying types of foods that they offer. So I think it's really important to make that connection with our help center just to find the right and best food for an individual. The second thing that the help center and outreach staff does is that they submit SNAP applications for individuals. And that is incredibly important because, as you may hear, for every 1 meal that the Emergency Food Network puts out, SNAP provides 9. So we know that SNAP is incredibly important in alleviating hunger. And so we take a very active role in enrolling people in SNAP. We also offer applications to other types of public benefits, things like TANF, even Medicaid, as well as referrals out into the community for things like employment services, housing services, and health fairs, things like that. So this is really important to understand when you think about the data that we're tracking and the outcomes that we want to understand and that have to kind of integrate with these referral platforms. So we've seen referrals from healthcare providers really increase a lot over the last few years. And just as an example, in fiscal year 19, we started tracking how many patients were screened for food insecurity, how many patients screened positive, and then how many were referred to our help center. So in fiscal year 19, we saw a little over 5,000 patients screened, about 14,000 positive, and over 700 referred to our help center. We saw that grow in fiscal year 20 to over 150,000 screens, over 16,000 positive, and over 2,000, well over 2,000 referred to our help center. And we expect that trend to really increase exponentially, especially with the adoption of these software platforms that make it easier for healthcare providers to refer. Next slide, please. So this is my last slide, and this is our experience with a referral platform to date. So we have been working with a referral platform for about 7 months. We've gotten a little over 800 referrals from one healthcare provider. And so just to give you an idea of our experience and kind of a wish list in moving forward with these things, a big pro, the biggest pro to us, is that the Hipaa compliance and the comfort that's provided to healthcare providers with these software platforms makes it so that they're comfortable sending the referrals. So that really increases the number of patients and community members that we're able to help, because we have had healthcare providers say, you know, we're not comfortable sending the referral because we're worried about the data transfer and Hipaa compliance. So, you know, that's unfortunate. We want to be able to help those patients. So that's a huge pro. We've also found this particular platform to be very user-friendly so far. Now the cons, it does take resources to train the staff. It's not something that's paid for. So all of these referrals that we're getting, the thousands of referrals that we're getting from healthcare providers, to service those referrals is currently unfunded. And that's probably not sustainable. We're already at a point where we need to hire really a full-time staff person to manage medical referrals. There's also a certain amount of loss of control over the data and outcomes that we would like to track. So when we are processing referrals on our own kind of customer relationship management platform, we're able to track whatever we want to track in whatever way we want to track it. When we're using a separate platform, so the one that we're using is another web-based platform, we receive the referral through there, we're only able to track that data in the way that that platform allows us to track the data. And so that is not really ideal. What we'd really like to do is fully integrate so that we can track it the way we want to track it. There are also, we've discovered some quirks and functionality issues in the software, and I'll just give you one example because it really does affect how we're able to service people. So when you're, if for example, then this is just our experience, if I'm a care coordinator and I'm searching for emergency food resources for a patient, one of the options is to search by a radius. So I may put in 5 miles around a patient's home address. Well, the Greater Cleveland Food Bank, as you now know, has one physical warehouse address, but hundreds and hundreds of food access points across the community. So a care coordinator out in Geauga County may be looking for food resources for their patient, and we wouldn't show up. And that's not a great situation because we have a lot of food resources there. So that's something where we really need to work with the software provider and try to fix that issue so that we're showing up accurately. So the last thing is our list of considerations and requests. We really feel strongly that regional collaboration and coordination is essential because it would be very challenging for us, and we're a fairly large CBO, but it would still be challenging for us to be adopting multiple software systems at once and training staff on multiple software systems. So trying to collaborate as much as possible. And then those interoperability standards are incredibly important because at the end of the day and longer term, it will make it much easier for us to track our outcomes if the referrals are coming in as if they're coming in through our own system. So what we really want to do is to link Pantry Tracked to whatever referral systems we're using. That will also really help our outcomes analysis. A third point is that the quality of the referrals really matters quite a lot. So what we don't want is for screening to be automatic and then for that to generate automatic referrals to us, because that will lead to a lot of referral or referred patients who may not want services. They may have been food insecure 8 months ago and they're fine now. They may not want help. They may have figured out something else. So having an intermediate person, be it a care coordinator or a social worker or a dietitian, looking at the results of the screening and then only sending appropriate referrals would be the most efficient way to do it. And then the fourth and last point is that the data sharing and user agreements associated with these platforms are important. Most community-based organizations are not going to have full-time legal staff or really the ability to have a large liability with signing a BAA. So keeping these data sharing agreements and user agreements as simple as possible is very important. That is my last slide.
Great. Lauren, you set the context perfectly, and panelists, you were wonderful, very informative remarks. And I personally learned a lot, and it spurred a lot of questions, ideas. I could probably talk all afternoon to unpack this information. As we begin the Q&A section of this program, I'll start with a few questions. This will allow time for participants to formulate questions and enter them via the chat. I know we've gotten a few already. And then Danny Carlson, Communications Director at the Center, and I will together lift up the questions from the chat. I'll start with the first one. Several of our panelists, and Tawny, you so eloquently talked about this with your focus groups. You referenced racism as a public health crisis and the impact on health in our community. And the issue of health inequity and racism is certainly a focus of the White House. Kate talked about the executive order and some of the other pieces. While using virtual platforms and increasing interoperability will help increase care coordination and track key data, we still have to do more to as a community to address these needs. So how can we leverage these platforms in this enhanced infrastructure, ensure that we do all that we can to address race and health inequity? And I welcome everybody's thoughts.
I'm happy to jump in here. Racism as a public health crisis can feel really daunting. And I think a lot about how to bring that down to an actionable level for an organization like a food bank. And where I tend to go with it is just more awareness around policy that's either created from a racist lens or has a disproportionate effect on a BIPOC population. And a couple that come just top of mind to me are, for example, underfunding transportation and a whole handful of housing policies. And so we see when people call for food that they don't just have food needs, they need other needs as well. They have housing needs, they have transportation needs. So for us as an organization, I think what we can do is to track that, to document that, and to communicate that up to policymakers to advocate for changes in those spaces.
Others?
It's a much smaller perspective, but I'll tell you that one of the things that we've done here in our community is we've removed from our referral platform any race data. So when a referral is received, there isn't race data that accompanies it.
I'll start next with a question for Alyssa. You noted a need due to increased referrals to hire someone to manage healthcare referrals. Do you have a funding source for hiring? And how did you expand your funding to be able to take on all these referrals?
No, I actually have a meeting coming up next week to talk about this because for the first year or so of receiving referrals, we were just fitting them into our regular work. So our Help Center and Outreach team does receive some funding that helps cover their work around SNAP applications. Not surprisingly, the referrals that are coming from healthcare providers, some people do still need SNAP applications submitted, and that's of course a huge priority for us, but it's a smaller percentage. So we actually really need to have some conversations around how we're going to fund this, and we're going to do the work, so if we have to fund it internally, we're going to fund it internally and fundraise for it. But really longer term, what we want to do is start to think about a sustainable source of funding. And ideally, this is something that would fall under a Medicare or a Medicaid bucket. But again, I would just say that incentives, like we want to really think through the incentive structure for funding this stuff, because we wouldn't want to, for example, just fund by volume, because the quality of that referral really is important. So if we're just going to be getting, we don't want anyone to have the incentive to send as many referrals as possible. We don't want to have the incentive to call as many people as possible, but we do want to figure out the right sustainable solution.
That's a perfect tee up. Really, Lauren, we've talked a lot about reprocurement, and I think a lot of questions are out there around what are the incentives baked into reprocurement around incentives, and how will that play out, as Alyssa's talking about?
Yeah, it's a really good question. And we've written a bit about this, and in the chat, you can find some of that available. The new provider agreement envisions going beyond HEDIS measures or clinical quality measures, and instead creates contractual conditions that allow for more innovative ways to contract with healthcare providers and others. So getting back to that risk, right? If we are incorporating social determinants and there's a conscious contemplation in that, in the money that goes to plans, and we now have that measured against seemingly non-healthcare related items. For example, some of the stuff that's going to be required to be tracked include things like the 3rd grade reading guarantee. What that means is that me, as like the managed care plan, the insurance company, I now see my bottom line tied into those social risk factors. And so it behooves me, right, from just a incentive standpoint, to try to come up with new ways of creating connections to organizations in meaningful ways. The thing that makes something like, Healthify or Unitas or these other referral platforms powerful is, if I'm CareSource or United or any of the other plans, to try to establish a contract with every single community-based organization is nearly impossible, right? Because then I have to go through all this HIPAA stuff again. I have to go through all the BAA stuff again, so on and so forth. And really, this infrastructure is hitting this market inefficiency. They're saying, we will manage the back office function, all the stuff that you need to get to scale for meaningful referrals. We'll track it, we'll measure it. And I think what a future state will be, what I am ultimately hoping to see from a policy standpoint, is then when Alyssa and her team address the food insecurity, the diabetic patient is able to get healthy, nutritious food, then they share in on those incentives, the bonus payments that would typically just go to providers or typically just go to insurance companies. Instead, community-based organizations that are doing the real work of upstream social risk management are the ones ultimately financially benefiting from managing all of this, because we haven't done a good job historically in managing those social needs as well.
That's a tee up to Cesar. I had a question for you. Are you working to help calculate the value? You talked about Jose and the process that he went through with CareSource, but how do we start to get to the real dollars and cents, and how is Healthify going to help support that calculation process?
Yeah, that's one of the key pillars of the work that we do, right? Is that once we have the data that comes in, is that we are holding our health plan customers' feet to the fire around proving out outcomes associated with it, right? So there's a lot of components associated with that, as you can imagine, because the last thing that we want to do as well is say to a social services organization that may not currently have any services that are reimbursed under Medicaid, to then say, you're going to go from 0 to value-based care on day 1, right? There are multiple steps in that journey. One first step is, in order for us to even prove out outcomes, you have to participate in this network. And how can we at least provide you financial incentive to be willing to participate and share data, right? So, and that could be, for some of our health plan sponsors, as simple as an upfront block grant to enable your participation in there, and then be able to use that data accordingly. From there, we then work to then figure out, well, what target populations can we actually address, that we can then see very much more targeted outcomes associated with very specific interventions versus just what is the impact of connecting to all social services, because that can also be incredibly hard. So we then work to figure out what are the pilot use cases, like Alyssa had mentioned, around food as medicine as a use case for very specific, we work to build out those metrics over time. But I think it's always just important is we, the collective we as a healthcare ecosystem, we're not there yet, right? So it's just the first piece is how do we make sure that there's at least transparency in data so that we can have the opportunity to prove out outcomes over time. And then we'll get there through fee-for-service reimbursement, through PMPM, and then through shared risk accordingly.
So we have a question in the chat. I want to raise this because there are a lot of participants that work for community-based organizations, but there are a lot of folks who are out in the community. We have a question from an elder law attorney. I think it's a great question. How likely is it that a good network of agencies can be set up to really help the great need for care out there? And how do folks like this elder care lawyer connect to this network? So let you guys respond to that.
Well, just in terms of how can they connect into the network, we want as many stakeholders as possible that are touching an individual, in this case, an individual Ohioan, to participate in the network however you see fit. So if there is interest from anyone to participate in the network, whether you want to make referrals into the network, get connected to organizations according to share data and coordinate that way, you just participate in the network, you reach out to us and we will get you access into the network accordingly. And it's as seamless as that, at least as it relates to that second question.
So we have maybe a time for one or two more questions. We had an earlier question that says, who owns the data? Who controls the data? And who is the payer for the services? There are groups who do a lot of referrals, but who supports and pays for those services?
Sure, I can speak on the health device side, right? There's multiple, platform providers and different network models that are in place. So I can only speak to what we do. In this case, as we mentioned before, who pays access into this network? Health system or at-risk health systems and our health plans, who are the ones that are at risk, are the ones that are financially incentivized to keep costs down. They're the ones that pay. None of our CBOs pay to enter or access into the network. They pay in other ways through their time, through sharing of the data, through coordinating these referrals. So that's something that we are very adamant about in our position, is that CBOs should never pay to access into a network or participate accordingly into a network. In terms of the data is housed within the platform. There are security provisions that are in place to ensure that we're getting client consent before that client's data can be shared appropriately across the platform. And think of HealthFire, the platform, as really just the highway for which data is shared. So then it's mutual shared data accordingly based on who's touching or coordinating that care for that individual. Accordingly. Was there another question there, Heather, that I missed?
I think you got most of it. We have time for one last question that was in the chat. And again, I think it's in a similar venue of an earlier question, but service coordinators work in many apartments throughout the area. We are a middle person between the medical groups and working where consumers live, also working on residents' needs and concerns. I see a lot of value in helping this process. How can we help? I'd love to get everybody's thoughts on that. And then I assume, Lauren, you're going to close us out.
Sign on. That's, my first thought is that it sounds like a really great opportunity or situation where your staff and your customers could benefit from having that information at your fingertips. But also it requires somewhat of a community-wide effort, because if you're the only player in the game, then the information isn't going to be helpful to you. So I believe it's about working together as a community and signing on and getting started.
Yeah, I would just add, there may be a really good opportunity there for screening, which is probably part of, you know, signing on to a platform, but screening and referring from the home environment is, I think, in many ways ideal. The more trusted you are as an individual asking the questions, the more likely you are to have an honest response, because those questions are really hard to ask. And we've even heard from some of our partners that, you know, a nurse walking into a room feels uncomfortable asking those questions. And, you know, the more you can build a relationship, the better that screening goes.
Great. Well, we're up against it. Thank you, first of all, to all our panelists. You know, if there's any follow-up that any of our folks have who've attended, they can reach out to all of you. Again, we'll make sure everybody's slides and a recording are posted online. I want to thank you, Heather, in particular, for being our moderator, and to Danny Carlson, our Wunderkind communications director, who makes sure that the ship keeps running and you know, does so with without being annoyed, given how easy it would be, given all the requests that I often give her. So thank you, Danny, for everything that you did. You know, for today, I think I just want to offer these last thoughts here. You know, there's been a lot of talk about the way that social determinants of health should be a part of Medicaid programs. And, you know, I think that that makes sense. You know, United States spends more on healthcare than nearly any other industrialized nation. We spend the most, actually. When you look at how much we spend alongside social services, though, we're sort of in the middle. And, you know, I think that this points to the fact that we don't do a lot to support community-based organizations, that we don't do a lot to help people with their basic needs. And it's organizations like Tawny's, like Alyssa's, that are meeting people where they are. I think regardless of the particular vendor, right, or the particular tool that we're talking about, ultimately at the end of the day, community-based organizations have largely been left out of the economy of healthcare and the scale of it. And if we want to get to something more efficient, if we want high quality services, we need to enable health and human service agencies to participate. We need to get rid of those barriers, because ultimately, and I think Tawny really spoke to this well, the bureaucracy doesn't exist in Columbus in the Lazarus building. The bureaucracy exists for individuals who have to go from one office to another with one application for another, to fill out another form, bring another form of ID, show another bill, try to make another bus. And that's how poverty becomes a full-time job. And I think what we can all do is invest in ways to make the systems work better for people rather than make people work for those systems. And so, you know, this is just one example of where there's some innovation in that space. I would recommend all community-based organizations, whatever platform we're talking about, ask, what are you doing for me, right? You know, not, you know, what you can do for the platform, but what is the platform going to do for you? What is the infrastructure going to do for you and your clients? Because I think that that's our intent here today. So with that, I want to thank everyone for participating. Again, our panelists, really appreciate your time, your energy, and your thoughtfulness. And thank you to all our attendees for joining us today. You can find more information on this and other topics that we cover at Community Solutions at www.communitysolutions.com. Thank you again, and have a wonderful weekend. Take care.